primarily going to talk about soft tissue sarcomas. And I'll lead off with the radiation part of things. But we're not moving the slides. There we go. So here are my objectives. We're going to talk about the rationale for radiation therapy. We'll talk about implications for on the pathology and how that affects our treatment recommendations. We'll talk about different radiation therapy techniques and then close out with at least one novel treatment approach that I think is very interesting. Kind of outside the scope of this talk is retroperitoneal sarcomas and then soft tissue sarcomas in the metastatic setting. There's a lot to bite off there, so I thought we should probably save that for a different symposium. So historically, recurrences happened primarily after wide local excisions. Standard of care through this era, this is in the 60s and 70s, was amputation. And you can see we're still recurrence risks of 5 to 15%, and then much higher with wide local excisions or what we call marginal resections. So we knew that if we were going to try to transition out of the amputation world, that we were going to have to do something different. And the first trial was the NCI trial from Dr. Rosenberg, where they randomized patients to the standard amputation versus wide excision, followed by radiation therapy to the extremity. The dose was post-operative, it was 5,000, followed by 1,000 to 2,000 centigrade boost. And concurrent chemo was given. And there was no differences in survival or overall survival. And so the take-home message was that smaller surgeries were safe to do, but that required radiation afterward. And out of this, we did find that margin was associated with recurrence, and that became sort of a driving feature of future management of sarcomas. So the next generation trials looked at, do we need to rate everybody with a soft tissue sarcoma? So they looked at high grade, they looked at low grade. The high grades were treated with chemoradiation or chemotherapy. The low grade had radiation versus observation. Similar doses, 45 gray followed by 18 gray. Again, the high grade received concurrent chemotherapy. And if you look at this is the local recurrence-free survival for all patients here, with certainly an excellent outcome in the radiation patients. When they looked at the low-grade group, there still was a benefit in local recurrence for those who had radiation, still with very excellent recurrence rates of less than 10%. And no radiation patients had recurrence rates of 20 to 30%. And then similarly in the high-grade group, I don't certainly believe this, there were very little, if any, recurrences. We know that's not necessarily the case, but that's just what happens when you start drilling down in subgroup analyses. Of course, the radiation, those who did not get radiation had a 20 to 30% risk of recurrence. And then about 10 years ago, they actually were able to publish a 20-year follow-up of this and had demonstrated very similar results. This is this overall survival. So of course, we wouldn't expect to see any impact in survival, but it's still interesting to see this long-term data. At Memorial, they did a lot of brachytherapy. So they looked at their patients either giving no brachytherapy, no external beam, or brachytherapy. They gave a little bit lower dose of 45 gray. And again, we still see this consistent benefit in recurrence. And so we're going to touch on this a little bit later in our techniques section. But through these trials, we've really shown that that combined modality treatment, wide excision, followed by radiation therapy was effective. It spared patients from amputations, and the addition of radiation reduced the risk of local recurrence. But there still are some patients who might not need radiation. We have now arms prospectively followed patients who did not get radiation, they didn't recur. Who were these patients? And so single institutions started publishing their data of who we may be able to omit radiation in. These tend to be patients with low-grade tumors. They might be small. Small definition would be less than 5 centimeters, but usually less than a few centimeters typically. Superficial location. I think the superficial location is important because it does allow for the next bullet point, which is wide margins of 1 to 2 centimeters. So this is a series of studies, different countries, different institutions. Basically, if, small, low grade, 2 centimeters, small, all negative margins, and recurrence rates are this kind of 5 to 15%, which seems to be an acceptable risk depending on location, radiation dose, et cetera. We are even observing high-grade tumors. They tend to be also small and superficial. That's not quite as common as these highly selected patients. So treatment approach. We historically gave radiation postoperatively, but preoperative radiation has several theoretical advantages. Surgery disrupts our normal vasculature. You have areas around the tumor that are hypoxic and therefore could lead to radioresistance. Second, post-op dose is often higher than preoperative dose. And so the thought could be that potentially we'd have some gains in local control and improved outcomes. Unfortunately, post-operative fields are larger. And another advantage of preoperative radiation is that target identification is easier with MRIs. So the Canadians did a trial, 190 patients randomized to surgery followed by radiation or upfront radiation followed by surgery. The dose difference was 16 grade difference. And as it turned out, a lot of the hope for preoperative radiation improving outcomes with regards to local control, progression-free survival did not come to fruition. Essentially, the tumor outcomes were the same. However, the take-home message from this trial was that wound complications were higher in patients who had preoperative radiation therapy. They were roughly double, 35% versus postoperative 17%. And this also, the one interesting aspect is this was typically confined to the patients who had sarcomas in their extremities, especially the lower extremity. There was no difference in complication rates in patients who had upper extremity sarcomas. However, the downside of postoperative radiation was they had more joint fibrosis. They had stiffness of the joints. They had more edema. Also accompanying the postoperative dose was the large field size. And with that larger field size, again, more fibrosis, more joint stiffness. And the investigators at Cleveland Clinic looked at their overall complication rate, and they divided it into acute and chronic. And so while they did see higher rates in their preoperative patients having acute problems, 22%, that did not lead to chronic problems, which was less than 5%. And they also found that the site mattered. So extremities versus other had more wound complications. Whether they received radiation, the degree of surgical reconstruction was a borderline factor. So weighing all this, we have on one side preoperative radiation with lower dose, lower field size, reduced swelling, reduced fibrosis. And the cost that we explain to patients is that we double their wound complication rate, although that might just be confined to an acute setting. Wound complication rate could be a simple outpatient infection managed with oral antibiotics, all the way to taking them back to the operating room, IV antibiotics, hospitalization, things like that. Of course, the postoperative radiation's higher dose, more trips to the radiation oncology, more cost there, larger field size with the subsequent fibrosis, edema, with lower wound complication rates. So today we kind of select patients depending on their location of tumor, size of tumor, how surgically, can Dr. McGarry take this out, or does he actually need radiation to help with his surgical resection? And then of course, pathology has lots of implications. Today, pathologists can actually help identify our soft tissue sarcoma much better than they did even 20 years ago. So instead of being kind of thrown into the bin of undifferentiated pleomorphic sarcomas or the old MFH, we now are able to identify what subtype of soft tissue sarcoma we're dealing with. And this really comes into play into these myxoid liposarcomas. These have to be worked up completely differently. The metastatic pattern of these soft tissue sarcomas is different than other soft tissue sarcomas. Typical soft tissue sarcomas will metastasize to the lung. These will metastasize almost anywhere in the body, soft tissues, bone, et cetera. So we have to work them up with a PET CT chest, abdomen, pelvis, and bone scan, even a body MRI, STIR MRI. The second important thing is that these have a dramatic response to radiation. So the historical thought is that soft tissue sarcomas have some degree of radioresistance, and that's not the case with this subtype. In fact, the investigators in Canada retrospectively reviewed 50 patients of all soft tissue sarcomas, and they measured the decrease in volume after radiation. And if they just looked at any high-grade soft tissue sarcoma, there really wasn't a change, which is what I prepare most of my patients for. Kind of the low-grade non-myxoids were about 14%, and then the myxoids had an 82% reduction. And so that helped lead patients to the Do-Re-Mi trial. This was a phase 2 trial where they just gave patients 36 gray and 18 fractions, which is what you'd expect to be woefully underdosing a soft tissue sarcoma, and they had excellent outcomes. And so this is now an option for our myxoid liposarcomas. Aggressive fibromatosis or desmoid tumors, these are essentially a benign tumor. They can be associated with pregnancy, trauma, et cetera. Our approach today is medical therapy or surgery, and then if they become inoperable or refractory to medical therapy, radiation comes into play. And our dose is low to moderate. It's 54 to 56 gray based on an EORTC trial. And really, you have some excellent outcomes. This would be a table of local control and survival after surgery and radiotherapy, and local control ranges from 70 to 90%. And so the question is do we ever add radiation after surgery? And my answer typically is no, because I don't think it adds a lot of benefit with regards to local control. So if you look at surgery alone, 60 to 70%, radiation alone, probably something similar. When you combine the two, you really are only adding about 10% to our operable patients. So I really hold on radiation until the surgery would become morbid or inoperable. And then we consider radiation if the patient were to recur. Another important subtype is the myxofibromas sarcomas. Myxofibromas sarcomas are very infiltrative. I think that they infiltrate well beyond what we can image on MRI. And as a result, these can have high rates of positive margins, higher rates of local recurrence. They can invade barriers that we would normally think would be intact, like fascial planes, et cetera. While the Memorial folks didn't really find a higher rate of local recurrence, the review of Harvard did, the review from the French did. And so we really consider when I'm addressing these patients with radiation, I usually expand my margins. If there's any soft call of what could be involved in MRI or not, I tend to include those soft calls of over-treating or maybe increasing my field size. I still give preoperatively 50 gray to these until we have data that says otherwise, but I do make sure my field sizes are larger. Radiation therapy technique is important, I think, especially in extremities. Distal, so calf or distal thigh, I'm routinely placing patients in a mask on their foot. And this helps minimize rotation and positioning. We usually have a vac lock. We can separate the leg either distance-wise or superior-inferior, depending on location. Brachytherapy has been often used for these. It's often a very focal plan. Basically, very little scatter dose can go beyond the margin of where we prescribe the dose, so it's very, very focused. But the folks at Memorial Sloan Kettering, kind of the pioneers of brachytherapy for soft tissue sarcomas, retrospectively looked at their experience of IMRT versus brachytherapy, and their local control was better with IMRT, and so that's been our standard here. So how do we plan these patients? Well, as many of you know, these soft tissue sarcomas can really extend longitudinally within a muscle compartment. And so if they are adjacent to nerves, they can track along nerves or vessels. They often distort adjacent soft tissues, which can lead to difficulty in contouring, and tumor can often expand beyond the mass itself with little wisps of tissue going along fascial planes, as you can see here. So in the 80s, they had a 10-centimeter margin for these patients, which was quite large. The NCIC trial in the 90s used 5 centimeters, which is in the old 3D era, similar to what we do today. An MRI study showed that you could have signal changes in T2 signal changes, an average of 2.5 centimeters away from the tumor. And if you look at where tumor cells are present, in 10 of 15 cases, they were well beyond the mass, usually within a centimeter, but up to 4 centimeters away. So I think standard today is to extend your your CTV margin beyond the tumor by 3.5 to 4 cms. And that's usually in the superior to inferior direction along the muscle fibers. So being very careful that muscle fibers aren't always oriented exactly sup to inf, top 6 o'clock to 12 o'clock. Muscles are often at angles. And so as you do your expansions, you have to make sure you follow those planes. And then radially, we expand 1.5 centimeters with respect to fascial or bone. Unique circumstances, though, are superficial tumors, where they're actually in fat, probably. And there you have to expand circumferentially within that fat all the way around 4 centimeters, or 3.5 to 4 centimeters. One thing we don't do as much anymore is give our preoperative radiation and then bring the patient back for more radiation. I'll do that in situations where Dr. McGarry is very concerned about the surgery. But generally speaking, when we have a planned close margin or planned positive margin, it's usually against a vessel or nerve, and we're just generally watching those. Kind of a novel approach is grid, or what now is considered to be lattice radiation therapy. This is being studied in sarcomas. Advances in planning and software have renewed interest in this technique. And the idea is you give a very large dose of radiation in spots throughout the tumor, which might kill tumor cells, but again, prevent regrowth in the low dose regions of this treatment. And ideally, this might be good for bulky tumors or what we would consider radiation resistant tumors. Lattice radiation is kind of the next evolution. It's basically 3D planning, usually with the VMAT or protons or particle therapy. And you create a series of hot spots and cold spots throughout the tumor. And this is what that looks like in different techniques with lattice or grid radiation therapy. And this is currently, I believe there's a trial going through NRG Oncology right now that might be looking into this for our soft tissue sarcoma patients. The idea is to give a single fraction of 15 to 20 gray, and then give your conventional radiation to follow. And then there's potential for giving concurrent chemo or giving immunotherapy in and around this treatment course following treatment. So that's all I have for the soft tissue sarcomas. So next, I'd like to introduce Dr. Sean McGarry. He is a professor in the Department of Orthopedics here at UNMC. He's the James Neff Professor of Musculoskeletal Oncology. Welcome, Sean.
Can you hear me okay? So my talk's a little bit more on kind of a surgical approach to soft tissue sarcoma with a little bit of a review of margins and how we kind of approach things. Here's my disclosures. So soft tissue sarcoma includes, or soft tissues obviously include skeletal muscle, fat, fibrous tissue, and the vessels supplying these tissues. Tumors of the soft tissue include those that occur within or are derived from those tissues. Tumors of the peripheral and autonomic nervous system are grouped with these as well because of similar anatomic location, histology, and treatment. So soft tissues derive primarily from mesoderm. Inclusion of peripheral and autonomic nervous system implies a portion comes from neuroectoderm. Soft tissue tumors are classified according to their theorized histologic origin, typically based on the adult tissue that they most resemble. So we have these benign versions, which have a limited capacity for growth, and then malignant versions, which are the sarcomas that we're talking about. These are locally aggressive and capable of distant metastatic spread. So this is kind of busy, but not even comprehensive, but the WHO classification, is it possible to move this bar? It just went away. So the WHO in actually 2013 is the most recent version of this. They describe adipocytic tumors, the benign versions being a lipoma, the malignant versions being liposarcoma. And you can see going through these. This is actually an older version of this. I'm sorry. Based on the tissue that they kind of derive from. So in 2024, there's actually about 13,000 new soft tissue sarcomas be expected in the United States, and about 5,200 Americans are expected to die of soft tissue sarcoma in 2024. There are some etiology causes. Genetic predisposition occurs in Li-Fraumeni and neurofibromatosis. They occasionally occur in chronic lymphodematous extremities. Patients treated with radiation and mastectomy will get often lymphangiosarcomas or just angiosarcomas. And chronic filarial infections can also cause sarcomas. There's anecdotal evidence of urethane, phenoxy acids, ethylene derivatives, Agent Orange causing sarcomas. And there's some thought perhaps of a post-traumatic. People often can relate a trauma, and we can always think that's probably just drew attention to something that was pre-existing. There's some thought that pluripotent cells involved in the reparative process post-trauma can go awry and lead to tumor formation. So growth characteristics. Sarcomas undergo centripetal growth until it reaches kind of the axial borders of the compartment that they're located within. So there's an intercompartmental membrane here, and it's filled up this anterior compartment. Usually respects fascial planes and usually displaces neurovascular structures. Here, once it's filled up that axial plane, it starts stretching and growing longitudinally. At the periphery of a tumor, we see this pseudocapsule, which is not truly a capsule, but rather a layer of compressed, rather atrophic cells resulting from rapid tumor growth. This occurs in what's called a reactive zone. It's edematous, neovascularized layer and may contain satellite lesions of tumor. Prognostic factors in sarcoma. Histologic grade makes a difference. Presence or absence of metastases do. Deep have a worse prognosis than superficial. Proximal, probably because they get bigger before they're noticed, have a worse prognosis. More specifically, size greater or less than 5 centimeters. So metastases for sarcoma are hematogenously spread, as opposed to lymphatic spread in a lot of the carcinomas. The exception being synovial sarcoma, epithelioid sarcoma, clear cell sarcoma, and angiosarcoma. Most common site of metastases are the lungs. If it's metastatic to other places, it's usually present in the lungs and then off to other places. An exception being myxoid liposarcoma, as Dr. Wall had told you. So the presentation for these patients, most of the time they present with a painless mass. Sometimes they give a history of a minor trauma. Predisposing conditions should be sought. Physical exam, it's important to figure out where it's located, any overlying skin changes, and a thorough neurovascular exam of the distal extremity. Laboratory evaluations, not particularly helpful in soft tissue sarcoma. Imaging studies, you'd like to get plain radiographs of the lesion. Although you can usually only see a shadow, this may give you a hint of things like a synovial sarcoma or extraskeletal chondrosarcoma or osteosarcoma diagnosis. You'd like an MRI of the lesion and a CT scan of the chest to rule out metastatic disease. So an MRI, we're only able to make a diagnosis about 25% of the time on an MRI, and these are usually benign things. We're very rarely able to make a histologic diagnosis of malignant lesions based on an MRI. Sometimes you get a hint of a liposarcomal component to it, but that's not terribly common. Obviously, we're getting a CT scan to look for metastatic disease. So biopsy, general considerations, poorly performed biopsies, poorly placed incisions, and biopsy complications can considerably compromise the subsequent local treatment of bone and soft tissue tumors. Biopsies should be performed by the person who will be providing the definitive care of the patient. So soft tissue sarcomas can seed wounds. We like to take our biopsy tracts out when we take the sarcoma out. So therefore, an appropriate location of the biopsy site is crucial to subsequent treatment. As you can see here, this black mark from here to here is the biopsy site. We like to make these longitudinal so that when we go to take the biopsy site out, we don't have to make as wide of an excision of skin, which can lead to difficulty in closing wounds. So again, longitudinal incisions should be made. Major neurovascular bundles should be avoided. Biopsy tracts should not traverse muscle compartments or joints to get to the tumor in another compartment. Standard surgical approaches are often inappropriate for these because they'll contaminate more than just the biopsy tract itself. We can do closed biopsies or percutaneous biopsies with this core needle. Advantages for this is I see a lot of patients that come a long distance to see me, and we can get a biopsy the day they come see me in clinic, and they can go home with at least their preliminary diagnosis. Disadvantages, sometimes there's sampling error, and sometimes we don't get enough tissue to make a diagnosis, and we have to go back and do an actual open biopsy in the operating room. So an open biopsy is an incision. Incisional is just a diagnostic tool where you get a sample. An excisional biopsy, you go in, you take an entire tumor out and then send that off to the pathologist to look at. This is typically only done for small subcutaneous things or things felt to be benign, because our approach obviously surgically is quite a bit different for sarcomas than it is for benign things. So preoperative planning for a biopsy requires communication between the pathologist, radiologist, and surgeon for determination of a differential diagnosis. And then when we do get that biopsy, a frozen section can confirm that we have diagnostic tissue. We don't always get a diagnosis on a frozen section. Oftentimes they'll say a high-grade spindle cell lesion, but that lets us know that they're going to be able to eventually come up with the correct diagnosis. So treatment, once diagnosis is made, treatment can proceed. Treatment is different for benign and malignant soft tissue lesions. Treatment of soft tissue sarcomas requires wide surgical margins and radiation therapy. Dr. Wall talked about the differences between pre and post-operative radiation. Although evolving historically, chemotherapy has not played a huge role in the treatment of patients with soft tissue sarcomas. To speak a bit about margins, my diagram here, the white on the inner circle here represents the primary lesion or the tumor. The gray is this reactive zone. These small little white are what we call satellite lesions. And then this is the normal tissue surrounding it. So the margins that we talk about in orthopedic oncology are intralesional, marginal, wide, or radical. Intralesional means that you go in and you basically kind of shell out the tumor itself. And we obviously don't do this for sarcomas, but for some benign tumors, this can be appropriate treatment. A marginal resection goes in and gets out all of the tumor and as much as possible of this reactive zone. This has a potential to leave behind a satellite lesion that can lead to a recurrence. A wide resection includes taking out all of the tumor in addition to all of that reactive zone and hopefully all of the potential satellite lesions. And this is appropriate for sarcoma when it can be done. A radical resection involves removal of the entire muscle compartment, usually meaning an amputation, is sometimes appropriate if a neurovascular bundle cannot be saved. So the role of radiation therapy, oftentimes a neurovascular bundle or structure within that bundle will lie within this reactive zone. So this necessitates marginal resection in this area here around the neurovascular bundle. The idea is that radiation can sterilize that reactive zone, and we can go in and do a closer marginal / wide resection and spare the neurovascular bundle and theoretically a limb. So pre versus post-operative, I won't talk about this. Chemotherapy in general, for localized chemotherapy, for localized disease, chemotherapy is not typically used. Rhabdomyosarcoma of childhood is a notable exception. In general, this is an older population with multiple comorbidities which poorly tolerates chemotherapy. Sometimes chemotherapy, however, is used as palliative or salvage treatment for patients with widely disseminated disease. These are some of the drugs that are used. So no consistent benefit in overall survival has been shown with any published reports of single agent or combination chemotherapy combined with their high toxicity and multiple comorbidities. It's not usually used. However, that being said, younger patients are being enrolled in protocols as long as they can tolerate the side effects. Again, I apologize. I sent the wrong version of this talk. I had a case to show you, but I don't have it on here.
Curtis?
Yeah, so, Astro guidelines give us recommendations for when to favor post-operative radiation, fungating tumor, bleeding. But really the most vague one is increased risk for wound complications. And it's a rare scenario where we purposely do post-op. So can you give some examples where you would highly favor post-operative radiation as opposed to pre-op?
So to think of some of the, when I started here, it's been a long time now, but I used to pretty routinely have a conversation and justify why we did preoperative. I don't often have that conversation anymore because it's kind of, I think if we did an informal kind of a raise your hand survey at one of our meetings recently, and it's almost exclusively pre-op, the exception being our OOP surgeries where somebody comes in and they've already had it taken out not knowing it was a sarcoma. Sometimes people come to me with these exophytic tumors that are growing out of the skin and they're bleeding, and we'll go ahead and take it out, close and get a healed wound and then do radiation. I don't know if you can think of.
And then just pathology, like sometimes we just can't get an accurate picture of what it is. So it might be a diagnostic approach too. That's pretty uncommon, modern pathology. Dr. Chaikin, did you have a question? Actually, with the Strauss trial, we're doing radiation less and less for retroperitoneal sarcomas. Oftentimes it's a discussion with the surgeon. Generally speaking, we're reserving it for recurrence, and waiting there. So that's probably the major change over the past few years. The question up here, what are the strategies being developed to reduce long-term side effects, improve quality of life for soft tissue sarcomas undergoing radiation therapy? When you design the radiation field, you boost the attachment area and give less dose to the rest, or not treat the attachment area. The boost volume does not depend necessarily where it would be attached. This would be exclusively in post-operative setting. It would generally include the pre-op GTV with a circumferential 2 centimeter margin as the boost volume. I believe that's what it's getting at. I wouldn't necessarily, in a setting of a close margin or an unplanned close margin, I would make sure that would be included as well. And then the question about reducing long-term side effects. I don't know of any biologic modifiers right now of fibrosis in the breast world. Vitamin E and pentoxifylline has been given to reduce potential breast fibrosis. I have used that rarely in young patients with extremity sarcomas who are concerned about function. They have some sort of athletic background. I don't know how much that really gets impacted in the soft tissues of muscles and fat. So I guess that would be that question. For Dr. McGarry, would you like the radiation oncology nurse to do differently to take care of patients when they're receiving either pre-op or post-op radiation therapy for sarcomas?
You guys take care of this for the most part, but they give them Aquaphor to treat the skin in that period between kind of finishing and letting the soft tissues heal enough to do surgery. We've kind of gone from maybe 2 to 3 weeks to more like 4 or 5 weeks to operating on these, just because I'd see somebody at 3 weeks and they drove from Western Nebraska and I say, oh, we're going to have to put this off a week. Can you come back next Monday and we can take a look at it? And it should be healed. But so we've kind of done that a little bit different. And for post-op, it's just kind of letting us know if there seems to be any wound issues developing or whatever that may be more than just a desquamation type thing, if there's wounds that maybe need to see the operating room or something.
I'd say that my biggest fear is I give preoperative radiation therapy and then for some reason you never see the patient. So I'm always messaging and communicating with Kirby and Dr. McGarry. That's always helpful too.